those of you here, thanks very much for joining. Great to have you. This is the latest in our series of webinars of CPD events, where we talk all things imaging with various partners. And this evening we've got Mr. Numan Shah, who will be talking about all things hip pain and when to refer for imaging. First off, I'm Tom. I'm the head of growth at scan.com. So I joined back in January 2022. And essentially, I work on the more traditional marketing side of things, and also work with pretty much every team across the business to create features and products for our users. I think most of you will know us, but just a quick a recap of who we are. So essentially, we're on a mission to really improve medical outcomes for everyone by speeding up time to diagnosis. We're actually started in 2017 by an osteopath, Jasper, who just through the course of seeing his patients would need to order imaging, typically for a letter that went into the NHS, and it proved, it took a very long time. So he actually just started referring into the independent imaging centres around that area, and found it worked really well. He was getting imaging super quickly, which allowed him to make a proper diagnosis and then come up with a proper treatment plan. So it really built from there. And really, we've kind of grown. We've seen pretty significant growth since then. So it started out as like a direct-to-patient proposition. But over the last couple of years, we have lots of clinicians and other people who use our platform essentially to refer their patients in for imaging. So there are a few of you who already use us for this, but essentially we've got various ways people connect to us. But the way that's used mostly is the portal that we have. So essentially it's super quick, super easy to send in a referral. And there's a few flows, but essentially you can put a referral in, giving some simple detail on the patient. The patient will then get a link to then book themselves. So they'll be able to then choose from a variety of centres based on obviously the modality that's chosen, but their location, so they can choose whatever is convenient for them in terms of price, location, that kind of thing. And then we essentially, once the scanning is done by the site, we then send the image and the report straight back to the portal. So you will be able to kind of view it and download it and then assess what to do since then. We have lots of status updates to keep people informed of where they are in the process. And yeah, it's just super simple to use. So before we get started, a little bit of housekeeping. We're happy to take questions as we go through, and just type them in the chat. I'll keep an eye out, and then I'll stop or chip in every now and again to address those. I mentioned we'll share this. It will be recorded, and we'll share it afterwards. And we'll also be sending around the certificates for the CPD afterwards. But what we'll also do just quickly is we're going to quickly launch 3 quick polls, which you'll see on the screen there, just to give us a bit of context about who's on the call, and kind of knowledge and attitudes of what you do currently for imaging. So we'll just quickly run these and see what we get. That's quite a few that are answered already. I'm presuming you can see those. So yeah, there we go. So we've got about 57% physiotherapists. We've got about 28% osteopaths, 4% chiros, and then we have sports therapists, about 9%, 2% surgeons as well. So that's that one. The next one, again, another super quick one, around imaging frequency. So how often do you refer in for imaging currently? Good to get a sense of where people's knowledge and things are at. Quite a few for rarely, less than once a month, fairly often, a few times a month. Cool. So yeah, that gives us a good answer. We've got about 2/3, which is relatively rarely. And if that's because there's patient base or there's no need, then it'd be interesting to know. Hopefully, you'll learn some kind of tips and gain some knowledge on when to refer, particularly for hip pain. So, yeah, about 2/3 really, just once a month, fairly often. About 30% fairly often, a few times a month. And finally, we do like to ask about confidence about referring patients for imaging. This does tend to vary. And maybe we do a follow-up one after this when we send the link around, seeing if that's changed after this. So we have rating scale, so 7 fairly confident, got a few not confident. So yeah, average, so pretty confident, but I think there's there's a fair few I think who probably do with a bit more info. So cool, let's get that there. Great, thank you for that. So that sets the context a bit of who you'll be talking to and who's in the audience. So I think at that point I will throw over to you. You can take it away.
That's great, Tom. Thank you very much. I really appreciate that. I think it's my second time on, so it was great being on the first time as well. So I'm back for much the same today. Should I share my screen now? Is that okay? Go ahead.
Take it away.
Thank you.
Interestingly, do we have to have an IRMER certification to refer? No, actually, we do have a layer of clinical due diligence that we can put on. So we have internal clinicians who are all IRMER qualified who do vet referrals. So theoretically, so you can put a referral through which we will vet for you. Obviously, depending on who the referrer is, sometimes we don't really need that. But so the answer is no, you don't need to. But essentially, we as Scan.com ensure that the referral that's sent in is of a sufficient standard to then get sent to the scanning center. And hopefully after this, then people will be more confident in referrals as well. But thanks, Paul, for that question.
Yeah, I think I just advocate for that as well. I think I've used the portal a number of times and I've asked my patients just to go on and self-refer as well. It's been a very, very efficient, straightforward process. So if you have any patients that you do come across that you feel that they need some imaging, you can either refer them yourself or they can do it themselves as well. So it's very versatile, very simple, very straightforward. So I definitely advise you to just go on there and just have a look at the system and see how it works. Right, so I'll dive straight into it. So I'm a hip and knee surgeon based up in the Northwest. My NHS practice is in Salford Royal, which is a major trauma centre, university, teaching hospital, and a tertiary referral centre. I also do some private work in and around Manchester itself. So I thought what would be quite helpful for people to understand is you'll see quite a few patients with hip pain. When is a good time to refer on to either get further imaging or to get more expert opinion as to what needs to be done. So if we just sort of go through the agenda very quickly, I'll talk about arthritis, which is a mainstay of most referrals that I receive, or degenerative joint disease, whatever you want to call it. There's an aspect of trauma in there as well. The dysplasia that does affect a number of individuals. Labral tears will be seen by the sports physicians, by the physios, and then knowing when to refer those on is quite helpful to know. Infection is an important one not to miss when patients are being first seen, although that's quite unlikely that you will be seeing a joint that is infected, but always have your radar on just to be aware of some of the signs and symptoms, and then some of the sports injuries that can occur as well as a result of activities in and around the hip, which I think are really useful to talk about. So if you look at this X-ray, it shows an AP pelvis, particularly focused on the right hip. It can show you the obvious changes in the right hip joint of arthritis. So we use a very simple mnemonic that I'm sure everyone's aware of called LOSS. L standing for loss of joint space. As you can see, there's little to no joint space between the ball and the socket. Whereas if you look on the other hip, there is a good amount of space. So there's loss, of joint space. There's osteophyte formation, which is a bit of extra bone that's formed in and around here. There is subchondral sclerosis. That means underneath the cartilage layer, which is obviously being eroded away. There is that increasing sclerosis, increasing bit of whiteness that you can see in the bone, where you get increased calcium deposition due to Wolff's law. And you also have subchondral cysts forming. And that is a whole constellation of arthritis within that right hip joint, compared to the left being more or less normal, I would say. So the key thing for me is when you see a patient who has got arthritis, do they get pain? That's one of the main features, but do they get pain nocturnally, i.e. at night, at rest, or when mobilizing? Because each of those three moments are very, very important. So if someone's just at rest and they're getting pain, that means that the arthritis is pretty severe. If they're getting nocturnal pain, that's a bit like sleep deprivation, which is a bit like torture, actually. So if you're trying to get to sleep and your hip pain is bothering you and you can't get to sleep, you're going to be really suffering during the rest of your day as well, not really be very functional. And obviously when you're mobilizing, if you're getting pain, that's also an aspect of if they have to stand or walk for their job, that may interfere with their day-to-day life as well significantly. So it's always really good to take a quick pain history to understand when the pain is worse and what exacerbates it. How is their function affected? Can they put their socks on? Can they put their shoes on? There's some really good, helpful, there's the Oxford Hip Score that you can use, which is a functional patient-reported outcome measure score, which you can use to understand, actually, these are the activities that people are affected. Like, for example, if they've been seated for a while at the dinner table, let's say they go to stand, do they feel that the hip feels stiff? So all those are signs which shows that the hip arthritis is getting worse, and maybe now is the time to think about referring them on. Think about the quality of life, their hobbies that they like to do. If there's like a little bit of DIY, woodwork, whatever they like to do, or gardening, how is that affected? Because quality of life is really important for all of us, to be fair. And fine, we will curtail a lot of these activities as we deal with the arthritis, but there comes a point where you start to lose the joy in life. And I think that's important, that we don't get to that level. So don't let arthritis get that severe. So we've got to make sure that non-operative measures are exhausted prior to referral. That's really important, because I think there could be some really simple measures that we can employ that can allow people to at least function, have that quality of life again, such as lifestyle modifications. Is there something that they're doing that maybe, can they change jobs? Is that possible for them? Can they do something more sedentary? Can they sort of think about losing a bit of weight if they've got high BMI? That's a possibility as well to think about. Doing physiotherapy, reconditioning their muscles, because arthritis, we know, tighten up the muscles, particularly around the hip and the knee. The hip girdle muscles become quite tight. And the physiotherapists are, we work hand in hand with my colleagues to try and alleviate some of this tightness and get the joint moving a little bit better, moving the muscles a bit better, and improving the tone. And that in itself can result in reducing some of the pain, because the muscles become much more efficient. I've anecdotally found hydrotherapy to be very, very effective for some of my patients, because it gives you that buoyancy in the water. It offloads the joint, allows the joint to function a bit better whilst in the water, and you can do the exercises really to strengthen up the muscles again, and that can be really, really helpful and beneficial. There's also injections therapy that can be utilized as well. There's various injections we have on the market now, but the ones that I primarily use in very mild degenerative symptoms or mild arthritis symptoms is PRP, platelet-rich plasma, which I find is quite effective in some of my patients that I select to have that injection. We usually do a course of 3, so 1 injection every 2 weeks, and then we review them usually after about 3 months to see how they're getting on. There is also Ostenal Plus injection, which is a hyaluronic acid injection, which we utilize mainly for mild to moderate symptoms. And if they've got severe arthritis, like in this x-ray, I would probably be offering them a cortisone injection as a first line, if that's something they've never had before, or if that is something they would entertain. So obviously we have some really good operative measures, such as total hip replacement surgery, which is probably one of the best procedures we do in orthopedics, with regards to the quality of life years achieved after the intervention. You've got conventional hip replacement surgery, which is what I do, which is open. through a posterior approach. We replace a hip joint to a artificial hip joint, and that can be related either to, depending on the person's age, to a cemented hip or a hybrid hip, which is half cemented, half uncemented. There have been further movements in robotic operations where it's still open, but there's a robotic arm that allows you to burr out your acetabulum and also to allow you to get good position of your implants. To be fair, the jury's still out as to if it actually improves outcomes after a year, but certainly in the very early phases, it has been found to have some benefit. So there is certainly something to think about there. Tom, I'm just conscious, I think I just saw some questions flash up. Do you want to, are they something we need to address now, or?
Yes, so we just had one from Claudia saying, is the cortisol given in severe cases purely to reduce pain for a while?
Yeah, so it's anti-inflammatory. So we normally inject a cocktail of cortisone. I normally inject 80 milligrams. So my colleagues only inject 40 milligrams. You choose whatever you're comfortable with. So 80 milligrams and with local anesthetic as well. So local anesthetic gives them immediate pain relief. Well, in most cases, it gives immediate pain relief. That usually lasts for a few hours, maximum about 12 hours or so. After about 24 hours to 40 hours, the cortisone kicks in, and that's the anti-inflammatory. So it's designed for pain relief. If they've got stiffness, that will probably not get much better. So that's something that you need to explain to them. If it's just pain, cortisone will usually help. If there's stiffness and pain, then it may not be as beneficial. But again, some people may want to just have the pain under control, which is their primary concern. And then for them, a cortisone injection is perfect. Absolutely fine. I'm just seeing some more questions flashing.
Yes, there's a couple. So Mindy asked, what are the advantages of the robotic procedure in the early stages?
So because the robotic arm that comes out, and as you're doing the reaming and the subsequent implant positioning, you can very accurately position your implants exactly where you've decided to put them preoperatively. Now, the hip is a very complex joint, and it's in fact very forgiving as well. So it's got a wide window of tolerance. So in essence, what we find is when you're doing your dissection, you're operating with a robotic system, you can afford to not do as much soft tissue damage inadvertently when you're operating. That's really important when it comes to knee replacement around robotic surgery. Not so much when it comes to hip replacement surgery, to be fair. But we are finding that some of these patients do find that they recover a bit better, they recover a bit sooner, so their length of stay can become less. But usually we find conventional robotic outcomes sort of coalescing and becoming about the same at around about between 6 to 12 months. So we're still waiting for more data to see if there is a longer term benefit to robotic surgery. We know that there is a short-term benefit to be gained, but longer term, the jury's still out on that. We don't have the evidence for that.
There's a couple of questions actually about injections. I'll ask them both. They are slightly different. So Nikki asks, first, what makes you decide to do a PRP injection over the others? And then Sarah asks, do you avoid injections in THR needed in near future? So yeah.
Yes, really valid question. So I think for PRP, like I said, my indication is somebody who's got hip pain, maybe even someone's got a little bit of degeneration potentially, which shows up on the MR arthrogram, which I normally recommend getting, which is you can get through scan.com anyway. You can get when you have that imaging available and it's been reported to a high level, then you can really understand what's going on in that joint. So if they've got a little bit of degeneration, a little bit of chondral thinning, they've lost a little bit of their cartilage, they've got a little bit of degenerative changes, they're just getting some amount of pain, let's say they gain like 5, 6 out of 10 amount of pain, then I usually give them a PRP injection. Obviously, examination is one other aspect of it as well. And when I examine them, and if I feel that the hip movements aren't very stiff, but they are slightly painful, then I would advocate for a PRP injection. And that's normally my indication for PRP. It has to be only mild degenerative changes, no obvious changes on the X-ray. The X-ray will probably be more or less normal, but when you get the MR arthrogram or MRI of the hip, which you can do as well, and if it shows some mild degeneration, then they're a candidate for PRP injection. That's what I recommend. Sorry, Tom, what was the second injection question?
Yeah, it was, do you avoid injections in THR
Yeah.
needed in the future?
Yeah, so I do. So I normally explain to my patients that if I give them a steroid injection, a cortisone injection, there's a theoretical risk of infection if I was to operate on them within 6 months. Now, there has been a recent meeting carried out in Philadelphia, which is called the Consensus Meeting for Prosthetic Joint Infections. And they've actually stated, using the Adelphi method of consensus, where you basically get a bunch of experts in a room, because we haven't got a trial for this. So you get a bunch of experts in a room and you ask them the question, what would you do? And they had a really good confidence level where they said, actually, we can wait up to 3 months after injection, then we can operate and do joint replacement surgery. But I still err on the side of caution. So anywhere between 3 to 6 months, if they've had a cortisone injection, I will not operate. If they've had a PRP injection, I'm quite happy to operate because it's all biological. There's nothing synthetic. There's no cortisone in there. It's a cortisone that increases your risk of prosthetic joint infection. That's the reason. So if they've had a PRP recently, I sort of disregard that. I'm not too concerned about it. If they've had an osteal injection, then I would wait again 3 to 6 months.
Actually, Graham's made a comment or us, which is maybe related to that, which says, knee consultants I've worked with are not keen to inject steroid in knees based on a hypothetical risk of post-TKR infection. Is this true for knees? And if so, is there also a risk with that with steroid injection?
Yeah, so precisely what I just said. So there is a theoretical risk of periprosthetic joint infection after a cortisone injection if you were to operate within if you operated within 0 to 3 months after the injection, in my opinion. So it really depends on your threshold as a surgeon. So if I'm honest with you, I will inject my knee patients as I need to. And if they need to have joint replacement surgery, they will have joint replacement surgery after the injection. So having a knee injection does not preclude surgery, in my opinion. But obviously, we've got different opinions out there, and people have different thresholds of what they're happy to go with. So, from my point of view, I've not seen any issues or problems with people having joint replacement surgery of the knee or the hip, and if they've had a prior steroid injection. But yeah, if they've had an injection and you want to operate on them within about 3 months, then I would avoid the injection. Yeah, agree with that.
Great, thank you. Sarah actually asked another question, which is on a different topic, but I thought kind of interesting on that. Along this, which is, are consultants in the NHS happy to receive a private scan, or is it best to keep in the system?
So it really depends about access to the scan. Now, I think that the great thing about scan.com is that the report is available, the images are all available, it's web-based and it's really direct. So even though I've seen some people privately and they've gone for a scan through scan.com, I can still see all the imaging, I can still see the report, so that's ideal. As a surgeon, my first primary concern is I want to see the report which has been reported. Everyone's different. Some people just like to look at the scans. I like to look at both. So I like to look at the report and I like to look at the scans. And any modality which will allow you to see both things, in my opinion, is valid. So if it's in the NHS and you tell a patient of yours, go get a scan from scan.com, provided that patient can reproduce that scan and that imaging, they might be able to actually, they can, if they just take their tablet with them and it's load and they got connectivity, they actually show it to their surgeon directly. That's not a problem. And that way, as long as the imaging and the report are available, not a problem. But if they're in the NHS, the way I don't think, Tom, at the moment, we have an ability to connect the scan.com images via IEP to the NHS PAC system, I suspect. Is that right?
We connect with various IEP systems, so I think there's a couple used. I don't think there's one standardized system, and forgive me if I'm wrong. We have lots of technical colleagues who are much more cleared up on that. But we do connect to some, and I mean, ideally, we're kind of saying we'll ingest any data and we'll send data out to wherever it's needed. As you can imagine, the system is quite fragmented. So, but we're always building new connections. But yeah, we can. That's the idea, is we can easily share. Frankly, it is easier in some instances than others. But that would be just because of the different tech being used. But ultimately, we do connect with anyone and everything. I think the other interesting thing is, and we see this on the direct-to-consumer side, we might put out a Facebook post and you'll get loads of comments saying, can't use these guys because you can't use your scans in the NHS. I think there's just a lot of misinformation there about, are you actually able to do that? And unequivocally, yes, you can. I mean, our point is that we aggregate the spare capacity just to get people seen quicker. You should be able to share it with whoever and whenever. And that's definitely, that's ultimately our aim. But it's interesting the amount of kind of misinformation out there and what you can do with it.
Yeah, so I think I would say if someone's already in the NHS system and they've getting, because I get that all the time. I get people who've had private scans, they come to me with a report, that's fine, but I do need to see the images as well. So if they use any provider that can do that, where they give the report and the images, like scan.com does make it very readily available, then that should be absolutely fine in the NHS. Now expedite how quickly they're seen, and also the management as well that can be given to them. So yeah, definitely I would advocate for that. Is that okay? Shall I carry on?
Yes, yeah.
Okay, cool. So I always like to flash up this picture because this is really important. So for a hip replacement, this is the gold standard. It's a 50-year follow-up following a hip replacement. Now, if somebody has a 50-year follow-up following a hip replacement, it means, so this X-ray was taken when the patient was around about 70-ish. It means that they had these hip replacements done when they were very young. So let's say around about 20 or mid-20s. And you can see these were carried out many, many years ago by Charlie himself, who's the pioneer when it came to hip replacement surgery. And you can see they were using rudimentary metallurgy then as well. So this is a 22.2 to 5 millimeter head. They used a plastic socket. They used a Mexican hat, which they used to centralize their drilling into the actual acetabulum. And you can see that this was a tri-wire technique where they used to take the trochanter off and then reattach it with the wires. And you can see similarly, that's what was being done on that side as well. Agree that there is some wear of the socket. I do accept that. And there's maybe a little bit of lucency around the socket, but the patient is functioning very well. So we don't need to worry about that. And it shows that even, in the 60s, we had things really, really well clued up as to what a good replacement consists of, a hip replacement consists of, and we've only just built on that. So we've already built on really good pedigree, and we just got better and better at doing hip replacements now. So more focus on trauma now, which is something that my physiotherapy colleagues, chiropractic colleagues would probably be seeing, and possibly even general practitioners in primary care would be seeing, is that they will see patients who've had a fall. Now, this could be potentially, high energy versus low energy. So if they've been involved in, a fall from greater than standing height, that would be classified as a high energy. Low energy is a fall from standing height. And that's normally what happens when you have frail patients who've had a fall from standing and they end up breaking their hip, like a neck or femur fracture. So that's something that we also come across for hip injuries. Obviously, if they've had any trauma and they're ambulating and they're mobilizing, they come to see you, then it's highly less likely that they've had an obvious fracture. Now, the reason why I say that is they can still have a fracture, but it can be quite, it may be subclinical or it may be occult, where the cortices are still intact, but there is some bone bruising, which may be apparent. So if you're not sure and you think that they may have had a fracture, you do need to get some imaging. That means an X-ray, and if the X-ray is normal, then most sensitive is to get an MRI scan of the hip, and to really get that quickly and expedite that. So again, I've used that on a couple of occasions with scan.com, where I've asked for the scans to be done fairly quickly, and the report's been quite expeditious in that respect. And I found that, thankfully it wasn't fracture at the time, but it just reassured me that there was no bruising or any edema within the bone itself. and that was really, really effective and really helpful for the patient as well. And it particularly reassures them that there's nothing more significant going on. But always be aware if they've had a fall, was it high energy or low energy? That gives you an idea if they could have broken something or not. Again, fractures is something very that coincides with trauma. It can be acute or chronic. Usually, if they've got an acute fracture, they will end up going to ED. If they've got a chronic fracture, which is more like a stress fracture, let's say, then that would be something that they may still come to. And then again, imaging is warranted in that phase as well. I do get quite a lot of young athletes coming to me with anterior iliac spine injuries where they've gone to kick a football, and you find that this fleck of bone comes off because the rectus has literally pulled off that bit of bone. And it's important to recognize that. So if they are a professional and it's a large chunk, then sometimes, very, very occasionally, we may need to repair this. But more often than not, if they are from the Joe public, then they will be treated non-operatively and just expectantly with physio, with analgesia, and usually after about 6 to 8 weeks, they will rehabilitate and get back to normal, more or less. Stress fractures I've already mentioned to you. If they've been complaining of pain in their foot for, let's say, a couple of months, and usually you find the neck of the third metatarsal or even second metatarsal involved, and if you press there with your fingers on their foot and it's painful, query a stress fracture, get some x-rays. If the x-rays are normal, get an MRI scan. With regards to stress fractures, I've seen sometimes the tibia as well, even of the femurs. People who are very active, people who are marathon runners, and they're complaining of tibia pain, shin pain. If they're complaining of femoral or thigh pain, get some imaging to confirm. Again, if x-rays are normal, always go to an MRI scan. Previous injuries, if they've had, that can also be indicative of a flare-up in the future. If they had a previous tibial fracture, it's been okay, but then gradually they've gained more pain. Always get further imaging, confirm what the diagnosis, then refer on if there's a refracture or a repeat trauma. Always assess their mobility. That's really important. Assess their function. So are they able to do the basic things that need to be doing? That's key and critical, because if people cannot get out of bed and do the basics like go to the loo and etc., their quality of life is going to be significantly affected and they're going to be miserable. So do assess what their function is like. And if their function is really poor and you've done your due diligence and you've looked into, there's no obvious fractures, but there may be something else going on, again, appropriately, you can request imaging, but if you're not sure, do refer onwards to MSK or to one of your orthopedic surgical team. Particularly if they've got ongoing pain, be aware of that. In a very, very small number of cases, it could be that they have had trauma, but that's just unmasked the possibility of some other lesion that may have been there precluding that, such as a sarcomatous lesion, like in their thigh or something. So they could have like a bone cancer or a muscle cancer or something. Now, I have to emphasize the risk of cancer in this scenario is very, very low. Just have an index of suspicion. That's all. Don't get too concerned or too hung up about it. If you are concerned, I always err on the side of caution. I will x-ray, I will image, MRI scan, I will bone scan. I have a low threshold to do that because at the end of the day, you do not want to miss anything. Again, if you're not sure, refer on.
So, I mean, Linda just asked, is MRI gold standard for stress? She had a consultant insist on a CT, even though the tibial stress had already been diagnosed on MRI. So I guess that speaks a little bit to what you just said there.
Yeah, so I would, as my first line, once I've got the x-ray, if x-ray is normal, I would proceed to an MRI scan. If the MRI scan shows that there is a stress fracture and there's bony edema, but there's not much destruction of the cortex, I'd be happy with that. But everyone's different. It depends on their threshold. If I find that there is there's a cortical break or there's some abnormality on the MRI scan, I very rarely get a CT, but I will only get a CT if I feel that there is some displacement or if there's some loss of bone, just to quantify that. But again, there's various reasons why people do different modalities, and CT is helpful if you've got a fracture and you want to see the bone stock, and if you're planning on doing some intervention. MRI is really good for diagnosing, is there a problem? So when you're not sure, particularly like a stress fracture, it can look normal on an X-ray. I always get an MRI scan. If the MRI scan shows that there's a stress fracture, there's not much else going on with the bone, I leave it at that. But if I'm planning to do something on that case, then I may get a CT scan. So that may be why that consultant got a CT scan. Okay.
I'd love to hear as well in the comments if anyone has some, because about this, I think there's something there about you mentioned kind of 3 different modalities, and obviously you're an expert and you do this day in, day out. But I do wonder sometimes if there's a bit of confusion about when would you refer him for an X-ray versus an MRI. I think you mentioned a couple of rules of thumb or a framework there, but it would be interesting to hear from people there if there's or if there's still any kind of thoughts or maybe frameworks or more kind of specific rules of thumb that you could tell people about when X-ray. I guess you got to hear X-rays for bones, but I think teasing that out a little bit it is important, because I imagine it can be a little bit confusing.
Absolutely, I think so. Your modality that you will refer for really depends on your local availability and how easily you can refer for. So, for example, if you can get an X-ray quite easily, I would always recommend that being your first line in most scenarios if you're not sure what's going on with the bone or the joint. So get an X-ray. If you can't get the X-ray, then you need to speak to somebody who can. So it may be, if you're in the community, it may be that you should refer to MSK Tier 1 services, or if you're in Tier 1 services, you should have access to most diagnostics except MR scan. I think in some places they're not always available. For MR scans, you may need to refer on to your orthopedic surgeons potentially. So it really depends locally how people are fixed up for imaging. But primarily, if you've got somebody who's had trauma or they've got some sort of joint problem, get an X-ray. That gives you the first line. I've had people refer to me with just MRI scans of the hip, and that's fine. It'll tell me in the report that there's degeneration, there's a bit of wear and tear, blah, blah, blah. But I will always get an X-ray, because an X-ray is a lot more valuable to me if they've got joint problem, because it visually shows to me very clearly what's happening with that joint. An MRI scan, it's got too much going on. I can see the imaging, but it doesn't give me that clear picture that I need in my mind to understand how I can best manage this patient. So that's where the difference is between a surgeon and a radiologist, how they will interpret images. And that's what we've got to be aware of. So if you're ever referring a patient on and you have got the ability to do X-rays, always get those done, because those are really helpful. If you get any other imaging, like an MR scan, and you think that's appropriate and indicated, get that as well. Is that okay? Is that sort of answer?
Yeah, I think so. And as you say, I think X-ray is a little bit more widely available. We still do a fair amount, but actually it's quite common, and certainly on the patient booking directly route, they will have had an X-ray and then they come for a follow-up MRI, because in many areas the wait for that is just a bit longer. So that is something we tend to see quite a bit of.
Yeah, perfect. So again, MRI is for soft tissues. If you're concerned about soft tissues, get an MRI scan. I think that's really important, like lumps and bumps and things like that, and stress fractures, tear. I'll talk about it a bit later on as well, but I think that's indicated. I think I just saw another question flash up as well, Tom, I think.
Yeah, it was actually just Rebecca talking about in Cheltenham, they get an MRI at the Cobalt, who actually are on a network, and then an X-ray. So they usually get the patient to go back through their GP for the X-ray. But yes, I mean, theoretically, we can, scan.com can provide those as well. It is pointing out some sites are multimodality, some just do MRI. So it's not kind of uniform across the network.
Yeah, I've referred people through your portal for various X-rays, MRs, CTs, etc. So it's all very, very easy, and it's nationwide, so it's really helpful. I just saw something else flash up.
Yeah, it's another question from Claudia. How reliable do you think ROM, which I assume is range of motion testing, and special tests are while assessing hip issues?
So that's a really, really good question, actually. And I'll tell you why. It's because I've learned over the years that I am picking up more things through examination now with more experience than I would have picked up earlier on in my career. So I would always recommend whenever you're, patient facing, after you've taken your history and you've got a bit of an idea what may be going on, always examine them. Firstly, the patients feel that you've done a good job, that actually that person, that practitioner, put their hands on me and actually examined me. Obviously using appropriate chaperone, etc. as well. But the reason why I recommend that you always examine the patient is because it gives you that feedback over multiple times when you do that, of how different patients deal with a degenerative joint. You'll just get an idea of how stiff that hip is. So I do like a almost like a pin rolling maneuver first, just a very gentle maneuver where I roll the leg, and I just get a feel for how stiff they are and how painful they are, how irritable they are. Then I do a straight leg raise to see, making sure that all the extensor mechanism is intact. I then, what I find really sensitive is I bend the hip to 90 degrees, and as I bend it, I do the internal external rotation. And as I do that, normally if they've got something going on in the hip joint, they will say on internal rotation, ouch, that hurts, I've got groin pain. That tells me pathognomically, more often than not, it's the hip joint. If I go external and they don't get a lot of pain, that's normally okay. If I go internal but don't get any groin pain and they get pain over the greater trochanter, over the trochanteric bursa, which we term the greater trochanter pain syndrome, etc., or trochanteric bursitis. If they get that, then I do palpate over the greater trochanter. And it may be that they may have trochanteric bursa and not necessarily hip pathology. So one examination finding leads me on to the next. And the only way I've been able to do that is by examining hundreds and thousands of patients over the years and gradually developing that repertoire of, actually, this is what I need to really hone into. This is what gives me a good feedback. And it then allows you to understand, actually, if I'm not getting much pain feedback from the hip when I'm examining it, I need to look elsewhere. I need to look at the knee. I need to look at the spine as well. So it all sort of funnels me into my algorithm as to, if I find that the hip pain on internal rotation is painful, they've got an x-ray, shows hip arthritis, barn door, and I've screened the knee and the spine, I'm pretty confident that if we treat the hip, we'll be fine. If I'm still not sure, I'll inject them. An injection is very low risk of morbidity. Can be very effective. Even if it's for an hour, they get some relief. That tells me very clearly this is where the pain is coming from. And we do sometimes do trigger point injections as well. So like iliopsoas injections will do, all these other things that I've highlighted for you. Ischial tuberosity, hamstring injections, symphysis pubis adductor injections, glute med and minimus injection of the greater trochanter injections. So all of these allow you to find the trigger point and then allow you to instigate your correct management.
Are there any times where you wouldn't do any imaging? So you kind of see it. Maybe you see a patient and you do your clinical. You take a bit of a history, give them the once over. Are there any times where you wouldn't order imaging, or is it generally you would do both physical examination and order imaging?
If I'm honest with you, like I said before, I've got a very low threshold for imaging such as x-rays. Now, the only age group I would think of twice about even getting x-rays is the younger age group. So if they're children and I've ruled out any excessive trauma, the hip joint moves more or less normally, they've got a little bit of pain, I palpate them and we find that it's maybe soft tissue. On balance, I may not always get imaging, but by the time I see them, because I'll be seeing them in my clinic, ED has usually done some x-rays or done some imaging, and I will invariably see them with an x-ray. If I'm just thinking, it's very uncommon that I will not get further imaging. Very uncommon, because our ability to examine somebody is affected by their ability to allow you to do the examination, number one, and number two, everybody has slightly different signs and symptoms. I'd probably say maybe only less than 5% of people I may not request any imaging on, but even that is probably less than 5%, to be honest. The vast majority, always I'll get imaging because I need more information. Unless I know barn door, this is what it is, I won't get any imaging. Like, let's say trochanteric bursitis, I palpate, it's confirmed, on clinical examination. I will, however, still send them for ultrasound guided steroid injection or whatever injection, PRP injection, because the ultrasound confirms the diagnosis and then they get the injection. So yeah, more often than not, I'll always get imaging.
Great, thank you. I'm just conscious of time. We do have another question for Graham, so I might come back to that in a while. We've got about 10, 15 minutes left.
Okay.
You did, by the way, just mention ultrasound. Are you gonna, is that something you could touch upon as well? I know we've got X-ray for both.
I am gonna, yeah, I'm gonna touch on that. So quite timely. So ultrasound scans, I'll normally get them for swellings or tendon injuries or any issues where I find once I've exhausted my X-rays, my MRIs, because an ultrasound scan is very, very good in assessing for dynamic problems, and dynamic problems are usually from tendons, and the ultrasound can in real time see what the excursion of the tendon is, if there's any sticking or what the problem is. And then my radiologist, I will ask them a very specific question, that is there some tendinopathy, is there some inflammation, etc. And they can turn on the Doppler to look at the blood supply in and around that tendon as well. So that's really effective. What I would always advise you to do is, if you're confident in requesting imaging, perfect. Always have a question that you want answering on that imaging. If you don't put that in, you will be none the wiser, because the radiologist will just look at a scan, tell you these are the abnormalities, these are all the things that are okay. But if you wanted him or her to specifically look at a particular problem, if you don't specify it, they may not specifically address that because everything else looked normal. So it's very important that when you do request, you know precisely why you're requesting it and what the question is. Once you have the question in your mind that this is what I need answering, put that down in the request, and the radiologist very effectively will pick that up and look at that specific area and then give you an answer, but with the rest of the report as well, obviously. So that's why I would suggest you always do. I want to touch on dysplasia because I'm sure a lot of my physio colleagues, chiropractic colleagues are going to be coming across dysplasia as well. Mainly, we see this that it affects women more than men. That's just how the cookie crumbles, to be fair. You also find that I will always get an X-ray for these patients because I do want to work out what the center edge angle is. Now, the center edge angle is basically worked out when if the hip joint is concentrically reduced in the hip and the joint space is congruous, i.e., if you can see my arrow, you've got good space around the actual femoral head, and you find that the hip joint is reduced in the actual central part of the acetabulum. If that's the case, then you'll work at the center edge angle, which is basically drawing a line from the middle of the femoral head, which is the center of rotation, moving it to the edge of the acetabulum that way, and then working out from that point there vertically from the edge of the angle again, and then see what angle is produced. And if the angle is less than about 25, more or less less than 20, sorry, then you're looking at someone with an element of dysplasia. Now, dysplasia basically means that the femoral head is not covered as much as it should be. It's less covered, so there's more contact stress going in and around the area of the joint that is remaining there. And that means that these individuals do get pain. And it's a matter of diagnosing that appropriately first. And the younger you can diagnose them, the better. Because then, if they're really young, they can even have some sort of pelvic osteotomy, they can have some sort of procedure to increase that coverage over the femoral head and give that hip joint some more longevity. Their native hip can survive for a lot longer. If we find some of my patients, when they come and see me, are very late on, they've already got degenerative changes, they've had dysplasia for many years, they've been grumbling on, they've never been happy, then to be fair, what we're looking at are injection therapies and then usually a hip replacement if that's what's indicated. And that's even in the young patient as well. So I do always recommend for them to start off with physio, core exercises, strengthening up the core, strengthening up the hip girdle muscles. It's all connected, works really, really well, and alleviates a lot of symptoms for a lot of patients, because by the time I see patients, they have either been neglected, or the diagnosis has not been made, or if the diagnosis has been made, the correct management has not been initiated. Once we diagnose a problem, we initiate the correct management, do the physio, do the exercises. We've got to reverse all of those years of weakness that they've developed in their muscles by doing the physio. Once we do the physio, we then move on to injection therapies if that's indicated. And if all of that does help but doesn't alleviate all of the symptoms, then we're looking at pelvic osteotomies and eventually a total hip replacement if they've got degenerative changes end stage. Again, the modalities I use for this to diagnose are x-rays. I'll also get an MR arthrogram, which is an injection that we inject a bit of dye into the hip joint and then get an MRI scan. That's a gold standard when you try and diagnose any intra-articular hip pathology in patients where the x-rays look essentially normal. I think I've just seen something else flash up for a question, possibly.
Yes, there was. Again, I'm just conscious of time. We've got about 5 to 8 minutes left. I wonder, should we just get through the rest of these slides? I think there's amazing.
That's fine. Let's get through them. There's not that many more left, so
great.
We should be
okay.
Then
I'll return to the questions.
That's fair enough. Okay. So I thought I'd just touch on labral tears, because we hear a lot of labral tears. We hear about, a lot of my physiotherapy colleagues, my MSK colleagues do refer labral tears in, thinking that they will need repairing, etc., etc. So I've got quite a specific algorithm for them. So on the x-ray, you will be able to see if there's a cam deformity, which is basically, if you can see my arrow, you'll just get a bit of bossing over the actual femoral neck head junction, just where you can see there in the red. And it's important to identify that, because some people say that is the precursor for that patient to develop arthritis in the future. That's something to be aware of. Again, if they've got pincer abnormality, which is where they've got over coverage of the head, and that could mean that they're getting inflammation there. Just in that first image, their pincer, the word pincer has been cut off. Sorry, apologies for that. And you will then examine them and look for femoral acetabular impingement. So that means flexion, adduction, internal rotation, indicates anterior impingement. And then the Faber test is flexion, abduction, external rotation. So those are different tests that you can do to assess as you cycle the hip around. You can then assess if the femoral head neck junction is compromised, and if they have got some femoral acetabular impingement. Now, if they have impingement, that is a precursor for labral tears usually. Okay, and you can just see with that white arrow where it indicates an undercutting of that labrum, and that's one of the pictures that will show up on the MR arthrogram for you. Again, I will always recommend physio for them, because for them to develop labral tears, that means the hip's not, the morphology is incorrect, and that in turn results in the muscle becoming weaker, tighter. So physio is one of the first treatments I always recommend. MR arthrogram, like I've already mentioned, is diagnostic for finding labral tears. I will do a diagnostic injection, like a steroid injection, into the hip joint for these type of patients, particularly if they're symptomatic of a labral tear. Now, if the MR arthrogram shows any type of degeneration in that hip joint, they will not be a candidate for hip arthroscopy. Please do remember that, because if they have any degeneration, then the hip arthroscopy is unlikely to help them. The indication for hip arthroscopy is diminishing year by year. A lot of the indication is very, very tight. If you've got a normal hip joint and you've got a labral tear that is not degenerative, then a hip scope will probably help. Not always, but probably will help. Okay, that's something to bear in mind. Like I mentioned, it's got limited scope there. One thing I do want to make clear is that if you come across anybody who's got a painful, swollen, hot erythematous joint, this picture is very barn door. I get it. You can see pustules, etc., on the scar line. This is most likely this is going to be infection, but it doesn't have to be this barn door. So just have that again on your radar when you're seeing patients. If they've had good relief or good effect after surgery, and then suddenly they start to deteriorate, always rule out infection. Have they had loss of function? Are they not moving as well as they were? Are they getting more pain? Has there been recent surgery? Is there been a scar? Is there any discharge from that scar? look for any systemic signs, any temperatures, any tachycardias, any fever-like symptoms, any night sweats. All of these things are important to look at. Get an X-ray, because that will help you to determine if there's any obvious effects going on at that moment in time. I normally get a CT SPECT if they've had a prosthetic joint in place. I don't think you get that in the community, but CT SPECT is a very specialist scan, which shows you here where there is a little bit of, it shows up like, essentially like a traffic light, a yellow, amber, red type of sign. And it's showing me there that there's a huge uptake around the patella region, and there's increased stress in that area. So that could indicate something. Again, sports injuries, like I mentioned to you, I use a lot of PRP injections for my patients because I see a lot of sports injuries. It allows you under ultrasound to determine exactly which structure you're looking at, and then you can inject directly into the particular area that you want to be injecting and helping to get that relief for your patient. There's muscle sprain that we treat, not always with PRP, but that would normally be with physio. Trochanteric bursa, I do prefer to use PRP for this because I found, again, anecdotally, we're collecting data at the moment. Anecdotally, I'm finding that trochanteric bursa symptoms improve much, much better with PRP rather than cortisone or steroid injections. Gluteal tendonitis, again, that can be beneficial by doing PRP injections, but again, a steroid injection is something that I would probably utilize as well if I need to, depending on how bad the tendonitis is on ultrasound. Physio, again, we need to specify specific exercises for this, and you know, hydrotherapy again can be very effective. Always be aware and ask the question, does your sleep get disturbed as a result of this injury? Because that means that they've got a higher amount of inflammation occurring, which would indicate to me that I'd rather use a steroid than PRP. PRP is good for mild to moderate inflammation. Steroid is good for moderate to severe inflammation. And that's why I put that there, PRP versus steroid injections. And some of these I will get my radiology colleagues to help me with, to do under ultrasound guidance, which we make sure we target very, very specific areas. Yeah, Tom, that brings me to an end. If that's okay, we can start the presentation there and target some of those questions now, if that's okay.
Yes, great. Thank you. And apologies for having to whiz through the last few slides.
No worries.
Be testament to my poor timekeeping and also all the great questions we had. So there, hopefully people got a couple of minutes to stay behind. I'll kind of do this from reverse order. We have Mannion Look, who said, would PRP injections use be influenced by the menopause or hormonal influences?
So, a really interesting question. I am seeing this a bit more in my practice now, where we're becoming a little bit more in tune with women's health, and I think menopause, hormonal changes do certainly have an effect on inflammation, and we know certain hormones do affect inflammation. Now, at the moment, that does not necessarily influence what I do practically yet, but in the future it may do, as to when we should target patients and when injection will be most effective. What I'm doing with PRP injections is I'm not regenerating anything. I've got to be very clear on that. When I do a PRP injection, I'm targeting the inflammatory cells in that joint, in that tendon, in that tissue, so I can reduce the inflammation. You reduce the inflammation, the pain gets better, patient can then rehabilitate, do the physio, then they can actually get onto a road to recovery. I always explain to my patients the injection is a small part of your treatment. The physiotherapy, the rehabilitation is a much longer part of your treatment, and that's just as important, if not more important, because that hopefully prevents a recurrence of your previous symptoms. So that's what we've got to be very, very clear on. And we need to understand that the injections are a small part of the treatment. Physio is a long term. And I find myself, I'm constantly educating my patients. You know, the physiotherapy does not work within a few weeks. It takes a couple of months, 2.5 months, continuous regular exercise. Only then you start to see a difference. Only then you start to see a change. Then you start to improve. They expect I do the injection, I'll do a bit of physio, I'm going to be perfectly back to normal. It doesn't work like that. Our bodies are very complex, very different. Our bodies are really resilient to injury, but once we do get injured, we do need to put it right in as soon as possible, so as to prevent those chronic neural pathways from developing, from getting we do get because of dysfunction, we lose some muscle mass, etc. So all of that thing we need to unwind when they see, when they come and see me, they've already defunctioned, they've already got chronic pain pathways. So we need to undo all of that, and it takes time.
Great, thanks. And the question from Claudia, so due to less coverage, would a certain movement like internal rotation be affected in the hip?
Due to uncoverage, yeah. So I would expect them to, if I do internal rotation, like the Fadir movement, I would expect them to have some element of pain. But again, not one test can determine that is the reason. So the uncoverage, and when you do the internal rotation test, if they get pain at that point, it doesn't mean it's the uncoverage that's causing you the pain. It could be that they've got some degeneration. So it's multifaceted. So the examination just gives you an idea of what may be going on. The imaging or cross-sectional imaging confirms what you're thinking.
Great. I think given we're a couple of minutes over, so I think we'll stop there. Graham, I know Graham is posted there's quite a lengthy question, but if that's okay, maybe I'll take that and I'll send it direct to you afterwards. And if you maybe if you apply, I can connect you to reply to that, if that's okay. That'd be great.
Yeah, no problem. No problem.
Actually, Rebecca's just made comments. I have to say it's very refreshing to hear you saying how important physical therapy and exercise is in the treatment process. It's not my experience with orthopedic consultants historically.
Yeah. We work hand in hand with my physiotherapy colleagues, and I think we've got to be that's the whole point about education and understanding what the aim here is with the patient. We're intervening, we're doing all of these really, really expensive things like injections, replacements, etc. But some people don't understand that it's a whole your body is an ecosystem. You can change one. I can change a joint. I change the joint. I don't change the muscles in and around that joint. Those muscles are exactly the same as they were before when they were affected by the arthritis. All I've done is intervened, replace a joint. The muscles and everything, the whole ecosystem around it needs upgrading as well. And the way we do that is with physio and with rehabilitation. And that's the importance of it.
Great. I think you just, a lot of comments echoing that sentiment. Thank you. So at that point, I'll just say, Mr. Shah, thank you so much again. Incredibly informative as ever. Lots of great questions. So thank you everyone who came and for your questions as well and your engagement.